So just a reminder of the improving population health theme and kind of the work that we're doing. So the aims are to expand effective local public health action on the terms of health and health inequalities, and building capacity for rapid evaluation of public health action and translation of that into practice. And we've got a whole series of projects, 8 projects at the moment, that are focused on evaluation and implementation. So we've had some work looking at evaluating air quality improvement. In fact, the paper from that has just been published today. We have a project looking at the Ways to Wellbeing program, so a large social prescribing program in Liverpool that we've heard about in previous ARCFESTs. The third project there is focused on local economic strategies, and one element of that is working with Preston and looking at the Preston model, which is one of the things we're going to talk about today. And also another part of that is working with Liverpool City Region Combined Authority on their employment programs. Got several bits of work supporting the sort of COVID response and work with Merseycare, looking at developing ways of better allocating community resources for community services to neighbourhoods based on their need. Together for an Active Future, that's a physical activity promotion programme. Restore is a project working with the city, with Cheshire and Merseyside, using big data to identify at-risk groups with a focus. Initial focus, we're looking at people with complex lives and also adolescent mental health, which links in with some of the things that Mark was talking about. And the project evaluating an intervention to prevent self-harm amongst people attending A&E departments for self-harm. Okay, so that's some of the projects that we've got. And today we're going to focus on 2 areas of work, and with a focus on initiatives that build community assets and reduce health inequalities. So the first of these is the Preston Community Wealth Building Initiative, where we're evaluating the health and well-being impact of that, which I'm going to talk about, and we'll have some time for discussion about some of the initial findings from that project. And then we're going to move on to hearing from Claire about the Life Rooms initiative. And we've been talking to Claire for a while about potential involvement of the ARC in evaluating that. So we're in the early stages of that, and so it'd be really good to get people's insights into how we develop that. And we'll have time for some discussion about that before we finish the session. So our project looking at the health impact of Preston's Community Wealth Building Initiative. I'm sure many of you are familiar with Preston. I happen to live just outside, so it's a town I know quite well. It is a sort of relatively disadvantaged town, as many places in the northwest. This just shows some of the kind of health indicators compared to the national average. It definitely has poorer health across a number of indicators compared to what we'd expect from other parts of the country. So really trying to address some of the sort of long-standing health inequalities that affect particularly some of the towns across the northwest coast is really crucial to the work of the ARC. And often these health inequalities have been very persistent over time. But and we all know that one of the sort of fundamental things that underlies those health inequalities is the economy and the economic inequalities that exist between places in the UK. And the UK has particularly stark economic differences between places, greater than most other countries in Europe. There's been work that the Health Foundation has done recently, trying to get a better understanding of how we can use economic development to improve health and reduce health inequalities. So the economy is a major contributor to these health inequalities, but not all economic growth necessarily leads to improvements in health. Some economic improvements are better for health than others. And that's because lots of these different factors related to the economy affects people's health. Whether that's employment, you can have economic growth, but have kind of fairly precarious employment as part of that, which wouldn't necessarily be good for health. Some economic development increases inequalities, so not necessarily getting the resources to the people who need them. It may not necessarily translate into widespread improvements in housing and education. And those are all the things that potentially lead to health improvements. So a really important question for people developing local economic strategies is what kind of approaches to economic development are most likely to benefit health and reduce inequalities in health. So Preston has been at the forefront of this kind of new approach to trying to influence the local economy in a way that both creates economic benefits, but does it in a way that promotes economic inclusion and equity in those economic benefits. And there are a number of elements of the sort of Preston model, which is called community wealth building, that potentially contribute to that. And there's a lot that potentially goes into that. But here I've just outlined some of the sort of major characteristics. And one of the elements of the work in Preston has been the role of these, what they call anchor institutions. So that's kind of large public or not-for-profit organizations like the NHS, local authorities, universities, housing organizations, that potentially are going to be based in those communities over the long term, and potentially spend quite a lot of money in terms of procurement within that local economy, and also are sort of big employers, and through their actions they can potentially influence what happens in that economy that can then influence whether economic development has some of these sort of health benefits. So some of the things that the anchor institutions within Preston have been doing is looking at their procurement policies. So where does the NHS buy its supplies from? Is it coming from the local economy, or are they bringing in that from elsewhere? Also looking at how those anchor institutions can support the development of local enterprises, investing local wealth, such as local government pension funds in the local economy, improving recruitment and employment conditions. So Preston was one of the first places that really started moving forward with the living wage. Preston Council was one of the first organizations to implement a living wage, and then they've influenced a lot of other organizations in Preston to implement a living wage, and that potentially improves employment and working conditions. Also looking at the use of land and property that's owned by anchor institutions for activities that promote well-being. One of the organizations that we're working with on this project is the Centre for Local Economic Strategies, and they've been working with Preston over a long period in developing their approach. And this just shows some of the sort of key points in that journey. It all sort of started around 2012, 2013, particularly coming out of the financial crisis and realizing that the kind of traditional model of trying to just get investment into places like Preston from sort of big multinational companies wasn't necessarily going to achieve what they wanted. So they really focused on what the organizations within Preston were doing. So some of that involved looking at, we're introducing the living wage in a number of organizations, looking at how much money was spent by these anchor institutions, and then working with them to see how they could move so more of their procurement was supporting the local economy. So by 2017, I think that the spend of those organizations within Preston's economy had increased from 38 million to 111 million. And also a lot of other sort of activities promoting a more sort of democratic approach to the local economy. And we've talked a bit about this in previous sessions, so I won't go into a lot of detail. But you know, so a lot more money being invested back in the local economy that potentially has an impact. And on the surface, there are lots of sort of a number of indicators where, for Preston, where it seems to have been having a beneficial effect at a sort of economic level. So Preston improved a lot in terms of the indices of multiple deprivation, more than most places. Some of these different indices that have been put together, so the Mobility Commission Index, Preston was one of the most improved areas based on that indices, and in the Good Growth for Cities index, it also was measured as having improved. There seem to be sort of some positive signs around employment and education. So it looks as if there's some potential benefits of this approach for the kind of economic development that's happening. So we succeeded in getting a grant from the National Institute of Health Research with the support of the ARC to investigate whether this had had a beneficial impact on both the sort of social and economic incomes, but also, more importantly, on health and well-being. So we have a project with colleagues at UCLan and Lancaster to investigate that, and there's a number of elements of that, including some extensive qualitative work that some of the team from Lancaster will mention briefly. And so really to understand what those impacts are, but also understand kind of what enabled those changes to happen within Preston, and what we can learn from that could be implemented in other areas. This is just from a sort of previous presentation that we had from the team at UCLan at ARCFEST, some of the quotations from some of the qualitative research that they've been doing about the Preston model. And I guess one of the things is that it's more than just the sort of actions of these anchor organizations, but it's also about sort of greater sort of solidarity within Preston, and people working cooperatively across the different organizations and groups in Preston to help bring about that change. So one of the initial bits of analysis that we've completed as part of this project has been to start looking at what effect we're seeing on some of these social and health indicators in Preston compared to other areas that are similar. So what some of the things we've been looking at is looking at the employment rate, wages, and this mental health index that we produced as part of the work of the ARC, the Small Area Mental Health Index, which is basically a composite of a number of indicators of mental health that we have developed for small neighborhood areas across the country. So we can use these indicators that we have for small areas to basically match places, match Preston to other places that are similar in some of these indicators, to then look at whether sort of improvements in Preston are better than you would expect from compared to other similar areas. So some of these indicators are just available at a kind of local authority level, and others are available at a small. So the main outcome that we're looking at, the small area mental health index, is available at a small neighbourhood area, which gives us a slightly more sort of robust approach. But this is just looking at some of the employment measures. So this chart just shows the employment rate in Preston, which is the sort of brown colour, compared to a control group of areas that followed a sort of similar trend in employment and have a sort of similar level of deprivation compared to Preston. And then we're looking at whether these things whether Preston has sort of diverged from that group after we would expect the impact of these economic changes to have happened, which is about 2015. And essentially we see that in terms of employment, employment has improved more in Preston compared to the comparator areas. So that's about 3.6 percentage points, so about 4 people in work per every 100 of the working age population additionally in Preston than would have been the case without this kind of intervention. That's what the estimate is kind of suggesting. Similarly, we see a sort of similar analysis looking at median wages, so the average wages of people in Preston compared to this sort of comparison group, following the very sort of parallel trends before 2015, but after 2015 we see an improvement in wages in Preston compared to other similar areas, and that's the equivalent to about an additional £14 per week on average for people in Preston compared to what would have been expected. And the main analysis that we're looking at is the effect on mental health. So this index we produced, a higher number is worse mental health, and generally we see across all areas sort of deterioration in this indicator, although part of that can be related to kind of increased access to diagnosis. But when we compare Preston to very similar areas, and this analysis is at a smaller neighbourhood level, we see quite a big divergence with Preston's mental health not deteriorating nearly as much as the comparison area. So we see actually quite a large effect definitely after 2015 of the Community Wealth Initiative on improving mental health compared to what we would expect compared when we look at a comparison group. So that is that's some of the initial findings from that from me. It does seem that definitely since 2015 Preston has experienced greater improvements in employment and wages compared to similar areas, and that seems to have had a knock-on effect on leading to better mental health than other similar places. But there's still lots of questions that are unanswered, and much of the work, we've only just started this project, and much of the work that we're going to be doing is to then try and understand those impacts better. And it could be that there are alternative explanations and it's not necessarily all related to this particular initiative, and then trying to understand what the pathways are. So it'd be really great to hear anyone's thoughts on that and how we can help other areas implement learning from Preston. So I will try and So if there are any questions on that, I can't see the screen at the moment. And any thoughts on those questions? Mick, I don't know whether you wanted to just come up with your reflections on that, and what you think you're taking forward to sort of get under and get a better understanding of what might be happening.
Right. Okay. Well, I mean, thanks, Ben. Can you hear me? Okay.
Yep.
Yeah. So, I mean, it's the first thing I want to say is it's really heartening to see the positive effects that have been found out, and these results have only come in really recently, haven't they? And I think myself and Julian and Nhs who were on the call, we don't see ourselves as just as researchers. We've sort of been involved in some of the laying of the foundations to make some of this Preston model work from early days, especially Julian, right from the get-go. So it is quite pleasing to see that there is a sort of measurable impact. I think some of the impacts are more, relatively intangible, difficult to put your finger on. I think there seems to be, if you knock around Preston and talk to people, there is definitely a sense of pride in place, at least for some people. I think that is a complex thing as well, in that, for the people who feel that they belong, there's always people who feel, other people who feel that they don't belong. So I think one of the more interesting things about local initiatives as they develop over time, and I think we need to see this Preston model as still a dynamic, organic set of practices that is going to develop and deepen and hopefully create more local value as it goes along, that people's experiences of it are dynamic as well. And I think that's what our project, the qualitative wing of our project, is trying to get stuck into, really. So, and we're only at the very early stages of this. We have done previous work. Nhs in particular, who's on the call, has done a whole raft of interviews with stakeholder groups. And I think for me, the big issue is, the people who know about the Preston model, the people who've been involved in it, if you like, the sort of leaders and activists in the process, they really get it. And I think they can see the value, and that obviously it's purposeful what they're trying to create. I think the question is, and where the jury is still out, is how deep does that go into the rest of the citizenship of Preston, all the residents. And given that one of the overall aims of this project that starts with economic justice is to try and deepen, everybody's participation locally, if you like, this sort of social democracy of the area and the sub-region. So, and I think the jury is still out there, but efforts are going on as we speak to actually, make improvements around people's connections to the Preston model as it develops, and to give people, more and more people a stake in its positive outcomes. And I think, a really interesting part of that is the desire to develop new cooperative workplaces, which are seen as a better way of both democratizing work, giving people, giving the workers an actual say about how their work is organized. And we think this goes right to the heart of what we might understand by what is decent work, what is good work, and how is that different from other forms of work that, let's face it, don't always please people. In actual fact, work itself can be a great cause of mental distress if you have the wrong sort of work. So, but the extent to which we've managed to develop these new cooperative businesses is relatively small in the swim of things, but will gather pace in the course of our project and beyond it. So one of the things I think we're most excited about is to see whether that sort of more democratic, cooperative workplace, social relations also translates into and connects with other forms of solidarity in communities.
Okay.
And obviously, sorry, go on, Ben.
I think you've raised some really interesting issues, and I just wonder if anyone else wanted to come in on some of those points. Rhiannon, I think you were asking about well-being measures. So one of the things is, so in the mental health index, it's more a measure of mental ill health than well-being. It's basically a combination of measures of the hospital data on mental health related admissions and prescribing data and diagnoses with depression and benefit receipt for mental health reasons. So it's so it doesn't have so much, but we are going to look at the ONS wellbeing data.
Good. That's actually what I was going to suggest, because that's available, I think, at fairly low level in neighbourhood indicators, isn't it? I think anyway. And also we did some analysis a good few years ago now, looking at well-being inequalities and the fact that they are really very tenacious and difficult to change. And it's exactly these kinds of models that have the potential to make a difference, I think, in addressing well-being inequalities in places. Liverpool, for example, has a very high level of well-being inequality, as you might expect, and it's been present for very, very many years, as far as we can tell from the data analysis. So I think that would be a good thing to introduce into this work. And of course, because it's about positive mental health, and you're looking more widely and away from things like prescriptions and so on.
Yeah, and I think there are definitely good reasons for looking at that. I think one of the things that Mick sort of raised, which I think is important in understanding this, is the extent to which, obviously there are potential benefits for mental health in terms of just a result of the kind of material benefits of more people being in work and better wages and things, but there are also potentially some of these more intangible benefits of sense of place and stigma associated with places, or getting rid of the stigma that's associated with some places, as well as there's more sort of cooperative ways of people interacting that potentially have benefits in terms of mental health and well-being. So trying to unpick those kind of pathways is definitely part of this project. Are there any other?
Ben, there is a question from Rachel in the chat as well.
Yes, yeah. The difference between living wage, the real living wage, and the foundational living wage. Which, I mean, basically the living wage sort of program kind of started a long time before the government started calling what their sort of minimum wage, calling it a national living wage, and it is set at a higher level than what's kind of stipulated nationally. And a lot of the organisations in Preston did take that up a lot earlier than most other places. Any other questions? Roberta, what have you put in the chat? Funding. Yeah, Roberta, you were asking about whether there was any specific funding. I think this is one of the things that's really interesting about this. It isn't that someone's come in with some external pot of money that Preston has kind of bid for, which is often the case for a lot of sort of previous regeneration schemes. This has very much been kind of homegrown in Preston. I mean, Mick and Julian would know more about that than me, the sort of origins of it, but my understanding is that it's very much grown out of initially Preston. Julian, you want to come?
Yeah, my question was about the very origins and how the idea came up, and you said that you are continuing, sort of like how do you feel about the continuation and getting embedded in the
I think Julian was going to answer your question. We'll come back on that.
Thanks.
Julian, you go ahead.
Yeah, thanks, Ben and Mick and everyone. I think one of the challenges of understanding the direct impacts of health, mental and physical health in the Preston model is that it's a still developing program. So Ben quite rightly pointed to the question of the living wage and procurement and anchor institutions, and that, if you like, is the first beginnings of the Preston model. But right now, at this very moment, you have the development of the Preston Cooperative Education Centre. So education and cultural change is becoming part of the process. You also have the development of the Northwest Community and Cooperative Bank. So you have a banking system that favours, if you like, ordinary local citizens and provides economic benefits in ways and financial benefits in ways that the high street banks wouldn't be able to do. So I think that what you have in as a feature of the Preston model, as opposed to the inward investment models of the past, or even very simple versions of community wealth building, what you have in Preston is a very holistic and systematic approach to economic and social transformation. Now, the paradox here, or the difficulty here, is the more holistic the system is, and the more holistic everything is in terms of being interweaved and embedded, one thing influencing the other, the more difficult it is to put your finger on exactly where the benefit comes from. So the benefit is likely to be greater, but at the same time, it's likely to be more difficult to pinpoint. And I think this is one of the challenges of our project, and a very interesting challenge too.
Yeah, and more difficult to think about how you might transfer that knowledge to another place and context, I think is one of the challenges. So I think we'll probably need to move on to Claire is going to be talking to us about another project which is also aiming to improve mental health and well-being, and it's going to be really interesting to hear what about that project and how we could potentially sort of support that through the ARC in the future. So Claire, I'll let you introduce yourself and we'll take us through your work on the life rooms.
Brilliant. Thanks so much, Ben. Can you hear me okay?
Yeah.
And can you see my screen?
Yeah.
Fab. Okay, yeah, thanks so much for inviting me to this. My name's Claire Rotherham. I am Social Health and Research Lead at a service called the Life Rooms, which is part of Merseycare NHS Foundation Trust. I'm going to take you through today a bit about what the Life Rooms model is, what it aims to achieve, its journey so far, etc. I'm going to think a little bit about some of the changes to the model that have taken place along the way, as well as some of the challenges and learning that we've gathered. Then I'm going to kind of focus on a new development, which Ben alluded to earlier, that the Life Rooms is embarking on, which is a collaborative piece of work with Public Health in Liverpool. I'm going to talk you through some of the evaluation plans we've started to generate in relation to that project, but we're still really early days with that one. So hoping we can kind of collaborate with ARC on some of this work. But just to give you a background on the model itself, so the Life Rooms Social Health, the Life Rooms as a service provides a social model, and we've been talking quite a lot about that today and in the previous presentation, but basically we're talking about those factors such as housing, education, employment, social connection, recognising that they have a significant impact on health and well-being, and building a model that responds to that. So our aim with the Life Rooms is to do that. So we talk about offering both a prevention and a recovery approach at the Life Rooms. So very much a mainstream prevention service. So we want to support people at community level to access support where and how they need to, so that they don't end up deteriorating. But also those people who have been in services, you know, that might be mental health or other clinical services or otherwise, to support, to engage kind of with community approaches and social approaches beyond that crisis. And we talk a lot about this term, the Life Rooms social model of health. Basically what I mean by that is that encompasses what the Life Rooms does, so the things that it offers day to day when people come through our doors, but also this kind of system change element. So this acknowledgement that as the Life Rooms, we're not just there to provide services. That's obviously a massive key part of what we do, but it's about encouraging and working within the broader health system to acknowledge the value of a social model. And there are lots of national guidance documents that point us towards this approach. Just to kind of in a slide show you our model and kind of what our aims are and what we want to achieve. So our overall aim is to improve population health, and we feel that we can try and do this in two ways: through health activation as well as system change. So through health activation, we have our 3-pillar model, which I'll talk you through shortly. Basically what people can get support with if they come into contact with the Life Rooms, supporting people to become more activated in their own health journeys. And then this system change element that I just mentioned. So we think that improving population health only involves working with people, individuals and communities, but actually also involves working with the wider system. And it's only through both of those things can we look to improve population health effectively. A key part of our model is what we call side-by-side. Lots of people refer to it as co-production, or meaning very similar things. We talk about side-by-side in our context as an aim to design, develop and evaluate services in a side-by-side way. This means the Life Rooms is shaped by everyone in the Life Rooms community. So that's people who access the service, people who work in the service, who volunteer, as well as that wider system of local partners, VCSE organisations and the wider community as a whole. So that's what we mean by side-by-side. And obviously, as people are aware, there's not a kind of strict definition or how-to guide as to how to deliver that. And that can be challenging. And we certainly don't always do it perfectly, but it's about trying to maintain principles of democracy, equality, collaboration and diversity when taking on evaluation projects, when delivering a certain aspect of the service, making sure that's inbuilt. Of course, it's about recognising people and community as assets and a massive focus on relationships. I really think relationships are at the heart of some of the approaches that we're talking about today. If people don't work together, collaborate, trust each other, build meaningful relationships, and I mean that in terms of the community and also in terms of kind of wider system partners, then we can't kind of build this more holistic system of support. So in terms of our journey so far as a service, we began about it's probably more like 6 years ago now. Initially, we're obviously a Mersey Care service, so we set up to really support Mersey Care service users, so people who had been under Mersey Care's clinical services for their mental health. So we set up in that way to support people with the social aspects of their lives, so that when they were, you know, coming out of hospital or getting support in the community, that there was somewhere they could go, they could feel safe, they could get some support on a more social level. However, we've now become a mainstream prevention service. So in terms of the Life Rooms and its sites now, we've got 3 sites, Bolton, Bootle and Southport at the moment, and we are open to anyone and everyone. So it didn't make sense for us to just target specific populations. Of course, Mersey Care service users are welcome and are a key part of what of the support we offer. But we are now a mainstream prevention service. And in terms of our aims to improve population health, I think that has to be the case. Before the Life Room started, the Mersey Care had recovery college provision, which many of you might be familiar with recovery colleges. And there's a real kind of focus on lived experience within recovery colleges at a more national and wider scale. And those principles, hopefully, as you can kind of see through that side-by-side slide, are still present within the life rooms today and are at the heart of how we want to move forward as well. I've put, should the NHS be delivering a social model? I mean, I obviously think yes, and maybe that's not a question that's asked so much at the moment, but it's certainly one that's been asked of us in the past as we've been setting up. But I think as we're kind of acknowledging through today's sessions, the previous presentation as well, acknowledging social determinants of health has to be part of an effective system of care. So why wouldn't the NHS be a part of that? And indeed it needs to be. And there are a number of different organisations, think tanks, etc. Ben mentioned the Health Anchors Learning Network, which talks about the importance of the NHS as part of this building, as part of improving population health in a wider system level. So we definitely see ourselves as part of that at the life rooms. And then in terms of what we offer, so if you came to the life rooms, what you would provide, we see that in kind of three main areas. So learning, so we basically would provide free courses, stuff around mental health, of course, but loads of stuff around arts, creative opportunities, as well as lots of physical health opportunities. And as I said before, that real kind of sharing of lived experience as part of the learning journey. Social prescribing, so practical social support delivered one-on-one. You can come into any of our buildings and receive that. You don't need an appointment, you don't need to fit certain criteria. And one of the key things with that, as you probably would well understand, is that in order to deliver that support, it's not just about the life rooms, it's about the wider sector, particularly the VCSE sector, and how we work with them to support people into the opportunities that they deliver. And then community, which is slightly less tangible, but nevertheless extremely important. So there's a few things here. So providing people with a place to go, effectively, a safe place to be and to be rather than do, and to feel okay and to feel safe. But also kind of as an extension of that, as part of delivering our services, working with the community to inform service design. So making sure that community is at the heart of what we're doing. And just to say that all the services are free and they're open to anyone over the age of 18, and that age criteria is expanding shortly as well, which I'll allude to in a couple of slides' time. So just a brief kind of reflection on some of the changes, challenges and learning. So one of the main changes, which I mentioned earlier, is we first set out to just work with people that use Merseycare. We've now, for many years been a service that's been open to all. And as I said before, I think that's super important as part of our improving population health journey. Challenge, as I said, we focus a lot on community and creation of community and working with community. And, as many people will relate during COVID-19, that's been a big challenge for us, and have done like any other organisation, all the virtual kind of routes. But I think that still remains a challenge as to how we do that effectively and build effective relationships in that way. Learning won't come as a surprise. We've touched on this in other presentations as well, but the importance of collaboration. So I really don't want to put across the message in this presentation that the life rooms can, do it all. That's absolutely not what we're setting out to do. We're setting to be part of this system, and we see ourselves as a hopefully significant part of the system with, the kind of umbrella of an NHS organisation around us to really help push the value of a social approach. But to do that, we need to work very collaboratively with the wider system. And so I just wanted to touch on a new development that the Life Rooms is embarking on shortly that I've referred to earlier, and just talk a little bit about what that project is and what we aim to do. And this is kind of some of the work that we hope to link in with ARC around. So Public Health in Liverpool have began some work investing some funds into a partnership model for prevention and resilience building across Liverpool. And they're working with the Life Rooms as part of their delivery of that, and because it really fits with our aims around improving population health. And so over a 12-month period, starting early next year, the aim of this whole kind of public health programme is to work with individuals and families to create an all-age family approach to building on community assets. So you can see how it really fits in with the Life Rooms model. So these this slide is about the wider public health aims. And in terms of how the Life Rooms fits into that, so they're working on, I think it's 7 work programmes delivering towards those aims that I've just outlined. The Life Rooms as a service were involved in 3 of these. And the first one is around early years. So it's around supporting existing service capacity and further developing skills. So in terms of our work, it'll be working really closely with children's centres specifically. So being present in children's centres, providing our support, but also supporting staff within children's centres to understand how they can get effective support for some of the parents and carers that they work with. The second point we're going to be working with them on is hopefully creating a community-based model for prevention, which aligns very well with how the Life Rooms works at the moment. And basically what that means is we're going to extend our support, so our learning support and our social prescribing support. It's already open to everyone, but we understand that it's not super accessible to a lot of people because of geography, etc. So to really kind of get ourselves out into the community, so out of public buildings, out of libraries, etc., to make sure people have access to this support when and how they need it. And then the third area we're working with them on is supporting the voluntary sector and providing a grants programme. So whilst Life Rooms has been given some resource from public health to deliver this, actually a good chunk of it is then going to be shared with the wider VCSE sector to support some of the broader aims of this project. So they're some of the areas that we're going to be focusing on the kind of next 12 months plus really. So over the next 12 months, we plan to deliver this across Liverpool, including from libraries and children's centres, like I mentioned. And, you know, the real kind of recognition and acknowledgement in this project is that everyone's had such a tough time with COVID and it's left a real significant impact. So people need this more than ever and really harnessing that value of community. So that's kind of our plans moving forward from sort of January time onwards is our, that's our hope to provide some of that. And my role is largely around research and evaluation of the Life Room service. And we've worked previously with ARC around a number of evaluation projects, which has been really interesting. At the moment, what we're planning is an evaluation project related to the public health work that I've just described. So how does delivering our services in this way, being out there in communities, how does it impact on the community of Liverpool? So we're in really early days at the moment, but we're hoping to do a mixed methods study to use some level of outcome measures to deliver a questionnaire, to look at usage data as well as demographic data, because that'll be really significant in terms of looking at who has got access and who hasn't. And also a good deal of qualitative work, so exploring people's experiences and understanding of their impact, the impact on their lives, whether they be users of the service or staff of the service, using focus groups and interviews and some case studies. So that's our broad thinking at the moment. Obviously, that needs to be given further detail, but also it's worth mentioning that at the heart of all that, we want that side-by-side approach to underpin this. So at the moment, I'm recruiting a team of staff as well as volunteers. There's a massive focus on lived experience and people that have used services to be a part of that. And the idea of that is hopefully that we can place that lived experience at the heart of the design and the delivery of this evaluation. So that's our hope for the evaluation around the public health project. And then in terms of wider research opportunities, we've been talking to Ben and other colleagues on this call around how we can further explore the impact of the Life Rooms on population health. And one of the things we're thinking about is how do we explore data linkage opportunities for the Life Rooms. So the Life Rooms is a non-clinical service. We don't link into secondary care, clinical records, etc. So how do we as a service link into wider population health data sets to look at where we can explore the impact of this way of working? So there's some of our thoughts. And I was asked to put together a few discussion points, but I'm obviously happy to take any comments or questions. But I think that role of the NHS in building community and fostering resilience is an interesting one to think about what specifically is our ask of the NHS in that, because I think that's really important. As well, how do we ensure side by side is at the heart of designing and evaluating community-based preventative approaches? And as well, kind of in the latter discussions of the previous presentation, what does meaningful evaluation look like? Because if you're having a whole system kind of change approach, a collaborative approach where there's many different elements working together, how do we think about meaningful evaluation? So I think that's a really interesting question as well. But as I said, more than happy to answer any questions or hear any comments. Thank you.
Thanks, Claire. That was really interesting, and some really interesting points in the chat as well about some of the kind of crossover between the work that we're talking about in Preston and the model that you're developing with life rooms, and the importance of trust and relationships in all of this, which I think is a really good point. Are there any questions that people have about that, or any points on the discussion? Roberta.
Yes, thanks, Claire. It was a brilliant presentation and so related to the previous discussion about Preston model. Actually, I have two questions. The first question is about data, maybe me, and it's sort of like it has been. Yeah, you posted a question about what a meaningful evaluation would look like, and of course it's sort of like we needed to take into consideration the lived experiences. However, I think especially when you talked about the new program, the sort of extension of the life rooms, sort of like I think a question to be asked is sort of like what kind of data you're collecting, whether sort of like you want to collect more data from this non-clinical environment, and also because as it has been pointed out at the CHI, for example, the session before, but also some of our feedback that I get, people and patients of the public sometimes thinks that service providers and commissioners have all the data in the world, whilst actually the data is actually quite scarce. So there has to be some sort of like some thought about that. So sort of like I don't know if we wanted to comment about this. The other thing that I was interested in is sort of what you mentioned about creating a collaborative environment for our first sector, charities, the wider community. Can you sort of like comment a little bit on the challenges and the opportunities of creating this? Because sometimes it can be sometimes in the social prescribing environment, it could be quite disjointed somehow, and how is it possible to create this organic network? Thanks.
Oh, thanks so much, Roberta. Yeah, definitely data. I really kind of hear you when you say, this kind of assumption that we've got all the data in the world, and actually it's actually a lot more challenging than that. I definitely align with that, particularly for the life rooms, because as I said, whilst we're in Merseycare, we are a non-clinical service, so we don't link up to the kind of normal NHS clinical record keeping systems. We've got our own record keeping system, which is very non-clinically focused. So then to do any sort of alignment work in the wider organisation, let alone beyond Merseycare, it can be very difficult to then kind of match things up and to do an effective piece of work. So we have done some of that, and indeed the ARC have supported us with some of that. So we have managed to do some of that work, but I think our focus at the moment is how we do that more effectively and at a bigger scale. So that's some of the conversations I'm really keen to have. Ease of data collection, it's again really challenging. We try to promote this ethos of you're not coming into a normal service, you're coming into somewhere nice and human and friendly, and this should feel nice. So to then say, what's your NHS number, what's all this, kind of challenges some of those principles and ethos that we're trying to create. So ease of data collection, I think we've got some work to do on getting our data collection right, but also how we balance that with the ethos of the service. And what people have told us is really important is some of that non-clinical feel and that community feel, rather than having to fill out loads of forms. In terms of collaboration with VCSE, that's really interesting as well. And we did a piece of work actually with Rhiannon, who's on the call, looking at the impact of our relationships with the VCSE sector, which was super interesting. There was lots of opportunities there and lots of really great work highlighted, but there were also loads of challenges. So I think some of that comes from the NHS kind of framework, if you like, VCSE perceiving an organisation like the Life Rooms with some negative connotations because we're part of a bigger organisation. So that kind of really hampered some of our relationships. So we've got work to do as a service to really kind of argue for and evidence that we want to work at a community level more than anything, and we understand the importance of that, and kind of work around some of the perceptions that are out there around the Life Rooms or Merseycare or the wider NHS. So that's definitely been a challenge for us and continues to be so, but it's something that we're really aware of and hopefully working to improve.
Yeah, I mean, I thought that was a really, yeah, a challenging but kind of interesting kind of issue really about, I mean, about your point about, clearly we want the NHS to take on more of a social model of health, that is surely a good thing. But there is this tension of, the NHS kind of moving into that space as potentially crowding out other sort of third sector providers. And yeah, it'd be really interesting if well, maybe Rhiannon has some thoughts on the best ways to sort of handling that.
Yeah, I'm not sure about best ways of handling it. I was just, it was putting me in mind of that sort of ambitious but probably failing NHS move towards NHS Healthy New Towns, which was I think happened a couple of years ago. We had an NHS Healthy New Town in Halton, but it stalled really, that initiative, and I think it stalled because other sectors like planning, for example, and the built environment sector felt that toes were being trodden on, or there wasn't a proper acknowledgement of the good work that had been done by other sectors. And that sort of brings me into a thought around how us as an ARC focusing on health and wellbeing inequalities really possibly ought to do more to bring in other disciplines and other sectors beyond health, because we're talking obviously about the wider determinants of health. And yet as a group of people, we're very health focused. And that for me doesn't sit particularly well. So I don't know whether that will open up any conversations, but unless we begin to talk to those other sectors and acknowledge the work that they've done in this area, then there will be these sort of critical points where the whole process will be disturbed because of a lack of communication, I think. Yeah,
I think it sort of comes back to those relationships again, of having those relationships, and maybe there's some things we can kind of learn from work in Preston around kind of how organisations have linked together. So I think the other thing that potentially hampers this trying to grow kind of capacity around the sort of social model is the sort of, well, the way we organise things and the way things are kind of commissioned around a kind of, which is kind of focused on competition. We basically set all the bits kind of competing against each other when potentially we need a model that is more about being cooperative rather than competing. Any other thoughts on that? I see your hand, Roberta. I'm just thinking if there's anyone else.
I was wondering whether sort of like the concept of anchor institutions that developed in in the Preston model could be something to go by, just in terms of both maybe challenging this sort of like this view of the NHS as an external to our sort of like of a purpose of a charity sector, but also sort of like as Rhiannon was saying about maybe the ARC to get a more proactive role in terms of sort of like to helping the system connect.
Yeah, I mean, I think there is something about you not seeing the NHS as a kind of commissioner of services, but as developing a kind of network of and more, yeah, which I think is more around the sort of anchor model. Mick, you might be able to put that in better words than I could.
Well, I don't know about that. I mean, I might be slightly off on a tangent, but it seems to me that the Life Rooms is in a really interesting position in that it is of the NHS, but it is also of the community. And I think the people who use the Life Rooms don't see it as the mainstream NHS. And that's partly the reason that people use the Life Rooms. So I think there's the opportunity to prefigure and shape different ways of doing things in a different space. And, you know, for instance, the stuff about aligning the work of the Life Rooms to the opportunity to put more money into local community groups and community action. And there's some great stuff at grassroots level going on in Liverpool. I'm thinking of the food justice stuff, things like Home Bake, Land Trust, and, you know, and all of these sorts of things. And some of them have been strangled for decades by austerity and cuts. And I think, you know, the group of people who coalesce around those points of action and places like the Life Rooms could, if the council trusted them a bit more and the NHS trusted them a bit more, be involved in actually determining how that money is distributed. And there are models for doing this that could work in a space like the Life Rooms and could even, you know, more energize that space and make it much more of a hub for democracy as well. So I think there's lots of exciting opportunities here, and it'd be a shame if it drifted into more of the same old, you know, especially in terms of the relationship of the anchor institutions. So I think the anchor institutions can be a great force for good, but let's not get carried away. They're not the sort of harbingers of democracy, and they have a vested interest in not opening up democracy. Yeah. But in smaller places, like say the Life Rooms and other hubs of community activity, we could maybe show how this could be done and then scale it up from there.
There's a role definitely democratizing the institutions, whether that's the NHS or other big institutions. We've got to wrap it up now. Rhiannon, if you can say what you're going to say in about 1 second.
I can, Ben. Yeah, I mean, I was really interested to see in chat Rachel's question about the Cooperative Education Centre in Preston and the new development there. And it seems to me that there is a very strong potential link between the work that the Life Rooms does, particularly in its recovery college type work, and connecting up the anchor institutions, the higher education institutions in that kind of way. I remember some time ago when I was health and wellbeing lead at the Heseltine Institute, trying to get the university involved in some of the educational stuff that the Life Rooms is doing, to no avail, I'm afraid. But it seems like that sort of time has come now. So it's an interesting way of thinking of connections.
Look at our own institutions and how they could be
yeah, exactly.
changed. So I'm sorry, that's all we've got time for. But I think there's some really interesting points. Well, one about learning that we can take from the work in Preston and apply in other places, and, you know, some of the stuff about relationships and working cooperatively rather than competitively is really interesting, I think, and hopefully some good points for you, Claire, that we can potentially take forward in supporting evaluation of the work in the Life Rooms. So thank you all very much, and hope to see you at the next ARCFEST. Thank you very much. Bye.